Good morning, everybody. Welcome to this morning's webinar, Contraception as a Quality Metric. We're going to be talking about the innovative work in Oregon being done around this metric. We are going to get started in just a couple of minutes. So we're going to give a few minutes for folks to log on and get settled. So if you need to, have a quick bathroom break or grab some coffee, you can go ahead and do that now, and we'll get started in just a couple minutes. All right, good morning, everybody. We're going to go ahead and get started with the webinar. The question I know that we're going to get today is whether or not the slides and a recording of this webinar will be available. And yes, they will. They'll both be posted to the Institute website. I sent a chat out with the link by the end of the day tomorrow. You'll also get an email from GoToWebinar to remind you that they're there. One note is that all of you are on mute today. So we have 56 folks on the webinar and growing, so everyone is on a global mute. There will be a couple of opportunities for you to provide some feedback via polls or writing in answers to questions, or then obviously providing your questions for Q&A. So please do that, and feel free to chat in those questions as soon as they come to you through the questions pane on the GoToWebinar control panel. It's really nice if we have some right when Q&A gets started to make the most of our time together today. This webinar is hosted by the Patient-Centered Primary Care Institute, which is a partnership that launched in 2012 with the support of the Oregon Health Authority and managed by QCOR. The Institute partners with experts to get technical assistance out to primary care practices working on the medical home model of care, or the PCPCH model of care. We hope to provide resources to practices at all stages of transformation to help build their capacity to support ongoing transformation and quality improvement in Oregon. We hope, if you haven't already, I suspect you have if you're registered today, to visit our website, pcpci.org. There are a lot of resources on the site, including recordings of more than 30 previous webinars like this one. You can sign up for our email list on the website, which is how we announce additional web-based and other training opportunities. So be sure to get connected with us if you aren't already. As I said, one of our key partners is the Oregon Health Authority's PCPCH program. The PCPCH program is the model of care the state uses to recognize patient-centered primary care homes. The model is defined by 6 core attributes that describe 33 standards that practices attest to become recognized. You can learn more about the standards in the program at primarycarehome.oregon.gov. And I am so pleased to introduce our webinar presenter today. Dr. Helen Belanca is a family physician with expertise in reproductive health. She's the co-creator of the One Key Question initiative to better integrate reproductive health into primary care. She was a key advocate for the adoption of Oregon's contraception metric, so who better to talk to us about it than her. And as a content expert, she was involved in the development of the specifications for the metric. She also was the chair of a national work group considering contraception metrics and participated in the development of the national metric on contraception. So grateful to have her expertise here in Oregon. She is currently the Associate Medical Director of HealthShare of Oregon, the state's largest coordinated care organization, or CCO. And with that, I'm going to go ahead and turn it over to you.
Great. Thank you so much, Kate. Can you hear me okay?
Yeah, we can hear you great.
Okay, great. Thank you so much for the opportunity to present today. I'm really excited about this topic. And I wanted to do a couple of quick disclosures. Do I have control of the slides?
Go ahead and click on the slides and you should be able to move them forward.
I'm not able to advance them. Perhaps you can advance to the next slide?
Sure.
So I wanted to give a couple of quick disclosures. As Kate mentioned, I'm currently the Associate Medical Director for HealthShare of Oregon, the state's largest CCO. And I'm speaking today as a content expert in this area and not as a representative of HealthShare or of CCOs in general. I have no financial interest to disclose, but I was previously employed as the Medical Director of the Oregon Foundation, a part in advocating for a contraception metric. Next slide. So our learning objectives today are to understand the contraception metric in Oregon and its specifications. This is a brand new metric, not only here in Oregon, but anywhere. So there's a lot of work that went into developing it and understanding what it's about. We want to compare Oregon's metric to the one being developed nationally. As Kate mentioned in the introduction, I've been involved with that work too, and they have a very similar metric. I know there are some folks on the call from out of state, and so there has been some discussion about that national metric, and we'll get into the differences between Oregon's and the national metric, and then discuss strategies for clinicians to improve performance on the metric. Go ahead. A couple of resources that you might be interested in. First and foremost, if you're interested in the specifications of the metric in more detail, they're listed on the OHA website, and that's the first link on this slide. And then there will be 2 free continuing medical education sessions for clinicians, one in Portland and one in Medford, and these will cover long-acting reversible contraception. So IUDs and implants, how to build them into your practice, how to counsel for them, and an actual insertion practicum. So I encourage you to sign up for those if you're interested. And then lastly, during the presentation, I'll be mentioning this quality family planning guidance that was put out by the CDC. It's a really outstanding resource. It covers all the basics of how to provide quality reproductive health care to women and men in your practice. So I would really recommend using that as a reference document. Please complete the post-webinar survey when we're done. And I want to pause here and say thank you so much, first of all, to QCOR and the Patient-Centered Primary Care Institute for hosting this webinar, and to Kate and Marissa for all their help in getting us organized. And then a special thank you to the Oregon Health Authority and the Metrics and Scoring Committee, because in the midst of all of the chaos and difficulties of launching CCOs, they were willing to consider a brand new metric that didn't have any national precedent, and that was a lot of work on their part. I want to give a special call out too to Sarah Bartleman. She's one of those people that if she keeps the world turning. So we're really grateful for all the time and energy she put into making this contraception metric happen. It certainly was a team effort, mostly on their part. So next slide. So let's start with a poll. I want to get a sense of the questions that you have before we get started into the content of the webinar. And my question is, what are your concerns about having a quality metric in contraception? We hear from all over the place about people's concerns. And I want to get a sense of who's on this webinar and what your concerns are. So one option is that you're unsure about the rationale. Why would we need a quality metric in contraception? The second one is you're okay with the metric itself, but you have some questions about the specifications. The third option is that you have questions about how a clinical system could approach quality improvement in the realm of contraception care. And then if none of those really meet your needs or meet your answer, then there will be an option to do a write-in answer at the end. So I'm going to turn it over to Kate right now.
All right, so if you want to go ahead and select your answer, once we have a sort of a critical mass from folks, we'll show the results.
Okay, so it looks like, and Kate, I'll try to advance, oh, you want to keep it to do the write-in? It looks like most
This is the results from folks who took the poll, and then anyone who wrote other, if you want to write into the questions pane and kind of share some of your thoughts with us, that would be great.
Okay, great. And so for the people who voted, it looks like most people are okay with the metric in general, but some have some questions about the specifics, and then the clinical approach. That's excellent because that's exactly what this webinar is focused on. We're going to spend just a little bit of time on the rationale, and most of the time on the specifics and on strategies that you can use to improve your performance. So Kate, maybe I'll go into the background and then we'll pause and hear other people's questions, okay? And I'll try to do the slides from here. Great. So it looks like that's me. Great. Okay. So a little bit of background on CCOs. Coordinated care organizations are a form of accountable care focused on the Medicaid population in Oregon. And I know most people on the call are here from Oregon, but we do have some out-of-state folks. And so accountable care exists in many different realms in healthcare, Medicare, and in commercial payers as well. But to my knowledge, Oregon's the only state that is building an accountable care transformation plan in the Medicaid population, and I think that makes us very unique. And accountable care just means that when in the process of improving the care, we need to show that we're not degrading the quality of care, and ideally we need to show that we're improving quality. So it really is a focus on metrics and measuring what we're doing to ensure that people are actually getting good care. So some of the requirements of CCOs are that CCOs must maintain a fixed rate of growth in spending. We must demonstrate quality care through our metrics. We operate a global budget for Medicaid that covers physical health, dental care, and mental health. That's a pretty important principle of CCOs. And then we are charged with developing alternative payment methodologies that support better care. All of this is aligned with the triple aim of the Institute of Healthcare Improvement, which is better health, better care, and lower cost. In terms of our metrics in CCOs, we have two groups of metrics. We have the incentive metrics and we have the demonstration metrics. The incentive metrics are really based on the performance of each CCO compared to a baseline. These are clinical metrics where we use clinical data, claims-based data from visits that people have with their clinicians, and we compare how CCOs are doing compared to how they did in a previous year at baseline. And each CCO is eligible for a quality bonus pool of money each year if it meets certain improvement targets. And that is prorated, if you will, depending on how many of the metrics you succeed in reaching your improvement target on, you get a certain amount of money. There's also a second set of metrics called demonstration metrics, and the purpose of this set is to compare the whole CCO population, which is all Medicaid members in Oregon, to the population of the state. And that's to get a view of how are CCOs doing in terms of everybody else in the state. Are we providing better care, worse care, the same care? Is the care getting better or worse compared to others in our state? So there's no money tied to those demonstration metrics. It's just showing how CCOs are doing compared to everyone else in the state. Both sets of metrics need to be negotiated with CMS, And that's an important point because it will come up later in terms of why the specifications worked out as they did. We had to follow some of the rules and guidelines that CMS set out for us in terms of building a new metric. So effective contraception has been in the CCO metric set since CCOs were created. It started out as a demonstration metric, and it was in that initial set of demonstration metrics. There was public testimony in 2011 that asked people to comment on what things we should measure to determine quality care in Medicaid. And at that point, the case was made for including contraception. And contraception was proposed as a measure topic in the early discussions of the Medicaid waiver that Oregon was having with CMS. And so it was there right from the beginning. It just was in a place that most people weren't aware of it because it was in this demonstration set. Since there were no nationally endorsed metrics on contraception that outlined a strategy for how you would measure contraception, when it was a demonstration metric, the committee opted to include it and use data from the BRFIS survey. That's the Behavioral Risk Factor Surveillance System. It's a telephone survey conducted by the state. It's a CDC-supported survey nationwide, and in Oregon, it's run by our public health department, where they call people up and ask them questions about their contraception use. And so we used data from the BRFIS survey to report on this metric when it was in the demonstration set. Then at the end of 2014, 2 of our 17 incentive metrics were being retired. We basically felt that they were no longer relevant. We had done a lot of work in both those areas and succeeded in reaching our targets on those metrics. And so we retired those metrics from the metric set, which left open the possibility for adding new metrics. So the Metrics and Scoring Committee entertained a number of different proposals for new quality metrics that we could add to the incentive set. And there were some really great ideas about what we should and could measure for quality care in Oregon. And among the many options that were proposed, contraception was one of the ones chosen. And I have to say that one of the reasons why it was chosen was because it was feasible to measure this with claims data. CMS had made the requirement of us that any new metrics that we added could not be metrics that we needed clinical data from an EHR system. We had to only add new metrics that we could get the numerator and denominator from administrative data, so claims-based data. And so contraception was one of those areas, as opposed to smoking status or food insecurity, that we could actually find the information in claims. And so that was one of the reasons why it was adopted in 2014. It was a very practical reason. It's an important health issue, but it also had this very practical component to it. So why is this important? I'm going to go through these quickly. We know that nationally 49% of all pregnancies are unintended, and that rate is 46% in Oregon. Of course, not all unintended pregnancies are unwanted. Some unintended pregnancies are happy surprises, but the bulk of unintended pregnancies are unwanted. And the rate of unintended pregnancies for poor women is more than 5 times higher than for women with more resources. This really is an issue for poor communities, and in the Medicaid population, it's an incredibly important concern. Interestingly, the rates of unintended pregnancy have not really changed in more than 30 years. We're about the same rate now as we were in the 80s, which is really distressing, and it is prompting a new approach to family planning and contraception that's more proactive and focused on quality improvement. This is a slide from CRAMS data. So that's also a survey data done from women postpartum. So these are women who have had a baby in the past couple of months. And we do this survey every year, again, through our public health department. And thank you to Emily Ellman for her help with this slide. But it shows the proportion of pregnancies that were unintended, but the proportion of births that were unintended in Oregon since the late 1990s. And you can see that it's remained pretty consistent since that time. And you can also see that the proportion of unintended births in Medicaid are almost twice as high as the proportion of unintended births in the commercial population. And that's, again, reflecting what we know from national data about how poor women are more affected by this. A woman with an unintended pregnancy is less likely to seek prenatal care. She's more likely to inadvertently expose the fetus to harmful substances. She's at greater risk for depression. She's at greater risk of physical abuse from a partner. She's also at greater risk of having her employment, having her education, or her relationship with her partner derailed by a pregnancy that she wasn't intending. A child of an unintended pregnancy is at greater risk of being born at low birth weight, of dying in his or her first year, of being abused or neglected, and of not receiving sufficient resources for healthy development. So unintended pregnancies really have significant health outcomes for both the mothers and the children. And of course, what everyone says, though, is yes, we understand why this is important, but how can we deal with adding contraception to our already very full plate in addition to everything else that we're doing? I'm a primary care provider. I'm a family physician. I've practiced in FQHCs around our state, and I understand the plight of primary care and everything that's being asked of primary care. And so really, this is something that's near and dear to me because I was on the receiving end of all these requests for many years. And my approach to this is to say that there are certain things that we do in primary care that are already very high priority. We screen women for cervical cancer. We are screening everyone for their alcohol misuse through our expert tool. We screen for breast cancer, depression, and diabetes. And no one would argue that we should stop doing those things. Those are all very important screenings in primary care. However, if you look at a woman's lifetime risk of those conditions that those tests screen for, they really pale in comparison to her lifetime risk of having an unintended pregnancy. So half of all pregnancies are unintended, but it's also true that half of all women will experience an unintended pregnancy in their lifetime. That's pretty stark. And we've made a big push and effort around SBIRT, and the rate of alcohol misuse among women is only about 10%. Depression even is about 27%. So this is really a priority issue for the women that we serve. They're more likely to have an unintended pregnancy than to have any of these other conditions. And so when we think about all the things that are on our plate and how do we prioritize certain screenings or certain efforts in primary care, I think this one rises to the top by the sheer prevalence of the issue. So I'm going to pause here before I get into the specifications and see if there's anything from Kate. Anybody wrote in any concerns that they wanted to be sure that we address?
Yeah, so someone, and again, folks, you can write those in through the questions pane and GoToWebinar. Someone wrote in about concerns about the concept of measuring LARCs or long-acting reversible contraceptives in the Medicaid population, but in no one else, that it could be interpreted poorly, that it's great to encourage asking someone if they want to be pregnant or not and if they're using a reliable method, but it gets a little tricky when it's only applied to one population, particularly around something as sensitive as pregnancy. So I just wonder, in the course of developing the metric, how has that been addressed?
Yeah, I think that's a really great question, and we will get into a little bit of how we measure LARCs. But I think the question is more philosophical about are we targeting one portion of our population over others? And we do have to be incredibly careful about that. We went round and round about how this metric should be structured because we did not in any way, shape, or form want to build a system that pushed contraception on women who didn't want it. We were cognizant of that risk from the get-go. And so really our framework for all of this has been quality improvement. That's the whole point of CCOs, that we want to reduce costs while maintaining or actually improving the quality of primary care. And how do we do that in the realm of contraception? We do it by being very careful about what we know about the population, by using data to drive the specifications of the metrics, and by setting our targets at low enough levels that we know we're well within the realm of women who want contraception. We have a lot of data on what women say that they want and need from their primary care, and we keep our expectations within the realm of what we know the population wants. So in terms of Medicaid only versus other populations, that's true of all of our metrics. I mean, you could argue that why do we care more about diabetic control in the Medicaid population than we do in the commercial population? It's just that we have started with an accountable care system in Medicaid as opposed to other systems. And I hope and expect that the model of CCOs will spread to commercial payers. There's already been some discussion about that in our state. And we're using Medicaid as the model of what great care looks like and hope that it spreads to other sectors. So contrary to being a hit in Medicaid, I think this is a real showcase of how to do high quality care, and we can keep framing it that way. So I'm going to, were there any other questions, Kate?
That's it for now. Just some folks expressing agreement with some of the ethical issues related to this measure and in the Medicaid population, but I think you kind of already addressed that. If there are any follow-up questions folks want to write in, please feel free to do that, and we'll get them next time we take a pause.
Okay. Yeah, I would like to get into that a little bit more as we go through. I'm going to start by looking at the specifications because I think some of that concern about the ethics of this can be addressed by how we dealt with the specifications. So I'm going to get into that a little bit, and then let's tackle that again at the end. So having a quality metric in the Medicaid system that addresses contraception with the aim of averting unintended or unwanted pregnancies is a huge step forward for the health and well-being of families. As I mentioned, they are disproportionately affected by unintended pregnancies. They have disproportionately low access to contraception, and so this is a quality issue. This is a place where in our Medicaid population we have not done a high quality job of providing the basic primary care services that families need, which certainly includes contraception. And this is a really big deal. This is a place where very few people, very few states, very few professional organizations have been willing to tread. Partially, you're right, because of the ethical concerns, contraception metrics have been proposed in the past that haven't really met an ethical standard in populations, and so they've been discarded. But I want to pause here to recognize that we think that the way we have structured this metric really is not only innovative, it's transformational because it gets at contraception in a way that really is trying to meet people's needs and is not coercive and trying to recognize a place where we have really fallen short in quality. I think we've really done it with this metric. We certainly are a national model. There is no other state in our country that has taken on contraception as a quality metric for an accountable care system. We're the first ones to do it. We had to be very careful doing it, but I think we've done a great job, and I think it's a huge achievement. So I want to pause here and recognize what a huge achievement it is. We're going to spend the rest of this webinar talking about all the problems and concerns with this metric, and I just want to recognize us as a state for really taking a step toward improving families' health and doing it in a way that made sense. So as I mentioned, contraception and pregnancy planning affect nearly every woman we see. There are very few issues that have such a profound impact on the direction of a person's life as whether or not they become a parent. And so helping women make that choice is going to be a key part of providing good quality primary care to them. Contraception is a core preventive service in primary care. It was specifically called out not only in the Affordable Care Act, but also in many expert-driven national documents on women's health and what are the core preventive services for women. Contraception is at the top of the list in terms of what women need in terms of improving their health. Oregon is the first state in the nation, as I mentioned, to use a contraception metric as an accountability metric. And really, the focus of the metric is on making sure that the systems that serve women are doing a good job at providing contraception. We're not asking that women use contraception and getting incentives based on whether or not they use contraception. The incentives are for the providers offering the contraception that meets most women's needs. So here it is. This is our metric, effective contraception use among women at risk of unintended pregnancy. And so part of how we get at the ethical issue around contraception is by really thinking about who's at risk of unintended pregnancy. The English translation of that metric language is that among women who can get pregnant but don't want to get pregnant, how many of them are using a tier 1 or tier 2 method of contraception? That's the intent of this metric. We really want to try to figure out the women that are at risk of an unintended and unwanted pregnancy and help them prevent that. If you're not familiar with the tiers of contraception, it's based on this WHO World Health Organization guidance here published by the CDC. The tier 1 contraception methods are the ones that are considered the most effective. They have a less than 1% failure rate. Those include the implant, the IUD, and male and female sterilization. The second tier of contraception methods are the ones that are most common, and they have a 6 to 12% failure rate. That means 6 to 12 pregnancies per 100 women in a year. Those include the depot shot, oral contraceptive pills, the patch, the ring, and the diaphragm. And then the third tier of contraception includes condoms and the withdrawal method and some over-the-counter methods like the sponge and spermicide, as well as natural family planning. Those are considered to have a high failure rate, more than 13 pregnancies per 100 women per year. So those are considered in the third tier, and those are not counted for the purposes of this metric. Part of why they're not counted is because they're not as effective. We want to get women to more effective methods if they're trying to prevent pregnancy. And the other reason why they're not counted is you can't figure out who's using them. Because those are all over-the-counter methods, we can't find a claim for condoms in the chart. So really the top two tiers involve prescription claims or visit claims that we can identify in administrative data. So who's in the denominator? Effective contraception use among women at risk of unintended pregnancy. So we want to find those women at risk of an unintended pregnancy. So we want to find women who can get pregnant, have a current male partner, but don't want to get pregnant. That's what we want. And women who can get pregnant, what we mean by that is that they're in the right age range, they have a uterus and ovaries, and they're not in menopause. I want to point out the age range here. We know that 15 to 50 is the reproductive age of women. But for the purposes of the incentive pool, only 18 to 50-year-old women will count in the initiative. We're going to be monitoring contraception use among teenagers, but those are not counted for the purposes of qualifying for the bonus pool. So the teens are just a monitoring one. And then we wanted to figure out a way to include knowing that a woman was currently sexually active with men and that she didn't want to get pregnant. But of course, those are not things that you can find in claims data. There are no codes for that. Women or clinicians don't ever put that in the charts in a way that can be found in code, so we can't find that. And that'll come up later when we're talking about the denominator. In the numerator, we wanted to find women who are in the denominator who are using an effective method of contraception, and of course that includes the top two tiers that I've already mentioned, and does not include the tier 3 methods. So how do you get into the numerator? If you use the pill, patch, or ring, we need to see a prescription claim code in the measurement year. If a woman's using Depo-Provera injection, we need to see an administration code in the measurement year. If she's using an IUD or an implant and it's inserted in the measurement year, we're looking for the insertion codes or the J codes, which are the device codes. And then if she had it inserted in a previous year, previous to the measurement year, we're looking for a surveillance code that she had it last year and that somebody checked in with her, hey, you had an IUD put in a couple years ago, do you still have it? How's it going? Sometimes women have those removed before it's time to have them removed. So it's just about checking in with women if it's still there and if they're still happy with it, and then documenting a surveillance code. For diaphragm, we're looking for fitting codes in the measurement year and surveillance codes if the fitting was done in a previous year. For female sterilization or tubal ligation, we're looking for a procedure code in the measurement year, and if it was done in the previous year, again, we need a surveillance code. Yes, this is a really crummy part of the metric because somebody had their tubal 5-10 years ago, and we have to ask them every year about it. It's a real trade-off in this metric. We'll get to it on the next slide of why we decided to do it that way, and we understand that it's problematic, but that was the only way to make it be rational. So vasectomy, condoms, over-the-counter methods, and fertility awareness are not counted in the numerator. We tried hard to put something in there for vasectomy and could not figure out a way to do it. So I want to point out here that we get it about some of the shortcomings of those specifications. What we want from the metric is women using a tier 1 or tier 2 method in the numerator, and in the denominator, women who are physically capable of getting pregnant, have a male partner, and don't want to be pregnant. But what we can find in claims data is women using a tier 1 or tier 2 method and women who are physically capable of getting pregnant. It's just a shortcoming of the metric. We are limited by CMS right now. They have told us that we cannot build a clinical metric right now. We are working on a couple of other clinical metrics in CCOs, and they're really problematic. Mining data from the EHR is certainly the way of the future, and it's certainly where we want to go with this metric. But at this point in time, in 2015 and 2016, we don't have the capability of getting this type of clinical data, and so we have to stick with the information that we can find in claims. So trade-offs and compromises, I've already mentioned some of these, but I want to call them out because this is what everybody is concerned about. Number one, this is a claims metric for a clinical issue. We can't know if women want to become pregnant from a claim. We can't know if women are having sex with men using claims data. And these two groups are women who are not at risk of unintended pregnancy, but they're going to end up in the denominator. So they're in the denominator. They're not going to have a contraceptive claim in the future, in the numerator. And so they're going to be just sort of a hit to the numerator. These are just women that are not going to be able to, you're not going to be able to get credit for these women. And how we accomplish that is by lowering the benchmark. And I'll go over that at the end of these trade-offs. The second trade-off is this idea of surveillance codes. They're necessary for multi-year methods because we were told that we cannot do any look-back. So you can't, in other metrics, you can say, starting today, let's look back 5 years and see if we find any evidence of a contraception method. And that way you could pick up a lot of IUDs and tubals that were done in the last 5 years. But we were told that look-backs were not permitted for this metric, that it had to be just data from the measurement year. And so what that comes down to then is that we have to use surveillance codes. Many, many people have suggested that we count women that have had tubals as women who cannot get pregnant and keep them out of the denominator. That way you wouldn't have to do surveillance codes for them with the idea that they can't get pregnant. There are two problems with that. One, they can get pregnant. It's a very, very effective method, but it's not foolproof. But the more important reason why we kept women with tubals in is because we wanted clinicians to get credit for all of that contraception that provides. That's one of the most effective forms of contraception. And if we exclude those women from the denominator, it's a pretty substantial proportion of the population that you wouldn't get credit for. And so we recognize that tubal is a common and very effective method of contraception, and we wanted to get credit for it and not keep it out of the denominator. So that's how we ended up with the surveillance codes. Here they are. These are the surveillance codes that are in the specifications of the metrics. You'll note that there's two of them, the second one and the second from last one, where they have an asterisk at the end. Those ones are going to be phased out. They are in the specifications for this year, but they're going to be phased out, and you can probably guess why, because it's unspecified contraception management, and people are using those for a whole lot of reasons, and we don't really know what it means. So for now, they're in there, but they're going to be coming out. The other ones are very specific to a method that you did surveillance of a previously inserted IUD or an implantable device, and then 25.49 is for tubal ligation, and then V45.59, the last one, is that there's a contraceptive device present. So some people prefer to use that one, like an IUD or an implant. You would use it for that. The third trade-off and compromise is that we can't count vasectomy, and this totally bums me out because vasectomy is the most effective form of contraception out there. And for that matter, we can't count any male involvement in reproductive health, and that is really a shame. We really need to make this metric much broader in the future to incorporate men. But for now, including men would be really problematic because it would involve figuring out how to pair men with their women partners in claims, and maybe the female partner's on Medicaid, so we want her in the metric, and the male partner's not on Medicaid, but he has a vasectomy. It's really complicated, and so we did our best to try and insert something in there to get credit for vasectomy, and we couldn't do it. For now, this metric has to only have women in the denominator. Most men rely on women to use contraception, and so including men in the denominator would really dilute the metric. The numbers would plummet if we included men in there, and so for now it's focused on women. When it advances to a clinical metric, we can think about ways to include men, because I think that's really important. Teens are also a really tricky issue. As I mentioned, we know that unintended pregnancy among teenagers is a big priority for a lot of clinicians, and we wanted them in this metric. But on the other hand, there are a lot of teens who don't use contraception and don't need it, and are abstinent, are not sexually active. And so, again, we didn't want to, this is where I think we made this compromise, because we didn't want it to look like this metric was encouraging contraception in teenagers. On the other hand, if teenagers need contraception and are using it, we wanted to make sure to get credit for that. So this is monitoring for 15 to 17-year-olds only. They're not in the pay for performance portion of the metric. Only 18 to 50-year-olds are in the pay for performance metric. And then pregnancy is really tricky. We wanted to be able to count the contraception that happens postpartum, but not punish clinicians if they only see women during the pregnancy and then they don't see them after the pregnancy. So it didn't seem fair to penalize clinicians for not offering contraception when the only time they ever saw a woman was when she was actually pregnant. So this is a really tricky issue. It was really hard to create a workaround. So what we did was when we're assessing the data for this, we initially keep pregnant women in the denominator. So we don't exclude them from the denominator. They're in there. Then we find the women who qualify for the numerator, and we have this other group that don't qualify for the numerator. We look in the group that didn't qualify for the numerator, meaning that they didn't have an effective contraception use method on record. And among those women who didn't qualify for the numerator, we look for prenatal care claims or a pregnancy claim. And if we find one, then we take her out of the denominator too. So in that way, if she's pregnant but she got contraception, she'll be both in the denominator and in the numerator. But if she was pregnant in the measurement year and didn't get contraception, then she's out of both. So it's a really a good, I think it's a very fair situation. It gives clinicians credit when they provide postpartum contraception, but it doesn't penalize them if the only time they saw women was during the pregnancy. So who's in this metric? So this is, again, our attempt to get at that idea that we want to provide high quality family planning care for women who need it, and yet avoid the ethical pitfalls and the implication of coercion that is really risky and inappropriate, frankly. So what we know from really good national data, this is the National Survey of Family Growth. They actually call women up and they ask them questions. It's a very detailed survey, and it's really rigorous and well designed. It's been used as a standard in family planning for many years. And what the National Survey for Family Growth tells us is that at any given point in time, they use 15 to 45 as their range of reproductive age. So at any given time, 70% of women 15 to 45 are at risk of an unintended pregnancy because they're physiologically capable of getting pregnant and they're currently sexually active with men. And I should have added in here, they're telling us that they do not want to become pregnant. That was a miss on this slide. And they're actually talking to the women in a survey. So they know they don't want to become pregnant, they're currently sexually active, and they are in the age range of the metric. 30% of women in that survey say that they're not currently sexually active or they're not sexually active with men. They are trying to conceive, or they'd be okay if they got pregnant. So that 30% of women are not at risk of an unintended pregnancy. They don't need contraception, they don't want it, and they are not in our target population. So this is where we feel like this is the opportunity for quality improvement. It's the 70% of every woman that you see in your clinic needs contraception because she's at risk. 30% of them don't. And this is a reliable enough survey that we feel like it represents the population. So what we decided to do, so here are the women that are excluded. Women that are excluded are the women physiologically incapable of pregnancy, women who were pregnant in the measurement year who did not also receive contraception. Those are not counted in this, so those are excluded from this metric. And what we decided to do with this metric is set our goal at 50%. We said that we think that 50% of all of the women of reproductive age that you see in your clinic should probably have a contraception method noted in her chart. And we felt like that was a really reasonable goal because we know that 70% of women need contraception, and so it was realistic to lower that to 50% as the goal for quality improvement. And it acknowledges that there are 30% of women in your population in your clinic who don't need contraception, don't want it, and shouldn't be counted in the metric. That was the way that we got around it, is really trying to focus on this as quality improvement based on what we know women need and not anything more than that. So how are we doing so far? We are currently performing statewide around 36% to this metric. That means 36% of women of reproductive age have a documented effective contraception method in their chart. That's actually pretty good. It's higher than we thought it would be. And we know that high quality system performance, so we set our benchmark at 50%. That means that we think that if you're a very high functioning quality system in family planning, about 50% of women will have a documented method. So that's the gap that we're trying to fill, is between 34% and 50%. That's our improvement goal. It doesn't have to happen in the first year. We set improvement targets for each year, and that's what the incentive pool is based on. So roughly it's about 3% per year. It's a complicated method to figure out what your improvement target is, but there usually is a floor of 3%. So usually the improvement targets are not less than 3%. So if our baseline performance in 2014 is 34%, our improvement target for 2015 is 37%. We just have to get 3% more women to have documented contraception in their charge. We know that 70% of women need it, and we're hoping eventually to get to 50%. So every year, if we get 3% more, we'll inch toward this 50% goal. But to get credit for the metric and to get the quality bonus pool, you only have to improve 3% per year. So that seems really reasonable to us. It seems well within the quality improvement situation and not in any way coercive or unrealistic. Okay, I'm going to pause here for questions because that was a lot.
Just a reminder, folks, you can write. Yeah, we do have a few. And if anyone else has questions, feel free to write in on the GoToWebinar control panel. So there's a first, there are a few related specifically to the metric and what's counted and what's not. So let's see here. So in looking at claims data, are you looking at least one code for each method? So would you be missing those women who only do one depot shot and then they stop?
Right. So let's say, yeah, so depot is every 3 months. And so if during the measurement year she only had one depot shot instead of 3 or 4 depot shots in the measurement year, she's still counted in the numerator. You get credit for that. We just need one code. We don't need to see a code every 3 months. It's just that if she got it once, she's in the numerator. So that's a shortcoming of the metric that works in your favor.
And so what about folks who use oral contraceptives or Mirena for bleeding versus contraception? So they're not using it for contraception, especially if provider uses a V code like contraceptive surveillance.
Yeah, that's an interesting one. Well, so in the case of, so in oral contraceptives that are used for non-contraceptive purposes, you're going to get credit in the numerator for those. But you're going to get credit because you have prescription claims. You don't need surveillance codes for, and you shouldn't use them because you're right, technically that's not contraception surveillance. But you only need the surveillance codes for the multi-year methods like IUD, implant, and sterilization. So in the case of a woman using contraception for non-contraceptive methods, we will see the prescription, the pharmacy claims, and you'll get credit for that in the numerator. Again, a shortcoming that works in your favor.
So, then a couple other questions that I'll just give you them both at once. So because there's no look back to prior year data, what about patients who came in earlier in 2015, but surveillance codes were not billed to OHP or the CCO at that time? And then along with that, what about ICD-10 codes for surveillance? In terms of your first question, they're not going to be counted in the numerator. We have to have a surveillance code in the measurement year, and so if it was, and it has to be in 2015. So but also there are exclusions to the numerator similar to other metrics where if they weren't continuously enrolled or if they're not a current member, then they're not in the denominator. So they might get excluded on those kind of technical reasons. But if they are clearly part of your member population and they don't have a surveillance code in the measurement year, then they won't get counted. And I apologize, I know nothing about ICD-10. I know it's coming, and I know that Sarah Bartleman at OHA has been working with a bunch of national experts on updating our codes to be ICD-10 compliant, but that's a realm that I'm gratefully not involved in. But they are ensuring that all of this is compliant with ICD-10. Yes, people at the state are on that. Great. And then 2 more questions. So will there be a way to count post-placental IUDs or Nexplanons placed postpartum prior to hospital discharge, or maybe contraceptive pills that are prescribed at the time of a discharge, so things that are happening in an inpatient setting?
Yes, absolutely. We just are looking for a claim attached to this woman. So it doesn't matter if the contraception happened in a primary care clinic, in a specialty clinic, in the hospital. It doesn't matter where the claim was generated. It will count. And to that point as well, I forgot to mention that many women see a primary care provider for most of their health concerns, and then they go to a family planning clinic either through the county or through Planned Parenthood and get contraception care at one of those specialty family planning clinics. That's okay. It doesn't matter. The contraception doesn't have to happen in primary care. So primary care clinicians are going to get credit, at least in this first year, for all of the contraception that happens outside your office. in a county clinic or in Planned Parenthood, as long as there's a claim attached to this woman and this woman is one of your members, you get credit.
Great, thank you. And then just one question, there was the slide that you showed around the 30% and 70% about women who are not currently sexually active, or some other items as well, and then women who are capable of getting pregnant physiologically and sexually active. And someone just wanted to have you re-explain that and then talk about the surveying.
Okay, yeah, so just really briefly, I really recommend that if you're interested in this topic, that you just Google National Survey for Family Growth. It's a huge data set with tons of publications, and it's a really well-regarded source for information on reproductive health and contraception care. So National Survey on Family Growth. But basically, this slide is showing that at any given time, we know that 70% of the women you see in your clinic are at risk of an unintended pregnancy because they're the right age, they're having sex with men, and they don't want to become pregnant. And we know that from this survey. And so perfect score on this metric, if you hit it out of the ballpark and got every single woman, you would get 70% on this metric. Because 30% of women don't want to be pregnant, or want to be pregnant, are not sexually active with men, they're not at risk for unintended pregnancy. A 70% is a perfect score, but we never set our benchmarks at the perfect score. We're trying to do realistic goal setting. So the benchmark, what we consider high quality performance, is 50%. The 50% number is something that the Metrics and Scoring Committee had to decide. They had to figure out where to set the benchmark. And they looked at high-performing systems in family planning, primary care systems, not like Planned Parenthood or family planning clinics. They looked at primary care clinics that were considered to be doing an excellent job of reproductive health. And in those clinics, about 50% of women had a documented effective contraception method in her chart. And so it's partly based on that, and it's partly based on this realistic goal setting idea that it feels like 50% is a reasonable target for all of us to aim for being a high-performing system. So the Metrics and Scoring Committee set the benchmark at 50% based on this survey data showing that 70% would be a perfect score, and we have examples of other systems who do perform at 50%.
So we do have a few more questions. We can continue on with those, or if you wanted to finish up your slides, we could finish these questions at the end. Okay, I'll defer to you, Kate. Is there one or two that you think we should address now that are specification oriented, or should we wait till the end? Yeah, actually. So there was questions about whether there's plans to move measurement of this to EMR data versus claims data, and would that improve the credibility of it? Someone asked about how the metric was tested prior to an inclusion, and then the final one was there any study of the percentage of women choosing natural family planning methods, so folks who don't use birth control for cultural or religious reasons? Okay, yeah, I can answer those really quickly. We really want this to be a clinical metric that uses EMR data, and that's years away. We just have to get the technological systems up to speed on that. It's all of our goals. Yes, it would be more effective. Yes, it would be more accurate. And we're all heading that way with all of our metrics, not just the contraception metric, but in the future, that's where we want to go. Claims were never meant to assess the quality of care given in a system. The purpose of claims and codes that we use are to get paid. That's what they're for. That's what they were designed for. That's their purpose. We've used them to assess quality because it's all we have. Before EHRs were prevalent, it's the only data we had on what happened in a visit. So it's just like with diabetes care. We right now have an EHR metric on diabetes care. And in claims, what you can find is that someone has a diagnosis of diabetes. That's all you can figure out in claims. But in the EHR data, you can figure out, when was the last time they had their cholesterol checked, and what is their hemoglobin A1C? Are they in good control or poor control? Are they on all the standard recommended preventive measures that we recommend for diabetics? You can find all of that in the chart, but you can't find it in claims. So claims are really limited. It's a really limited data source because it was never intended for quality improvement. But as our systems get better, as we get better at working with our EHRs and mining data from them, yes, I'm hoping that this and many other metrics will transition to EHR-based. In terms of did we test this, we ran some tests. The state did, OHA did some test drives of the metric.
where they just looked at a bunch of different sources of claims data just to see if we could find these type of measures there. And yes, so there was a little bit of that going on. But honestly, we're pioneering this kind of metric. This is a big learning curve for us, and nobody else has done this, so we don't have a lot of, we're sticking our necks out on this one for sure, and I think it's a good reason to stick your neck out, and we're going to learn a lot as we go through it. And my next section just talks briefly about the national metric and how we're working together, and that'll give more information about that. And then for national family planning, I know there are a lot of women out there who choose that method, and it works very well for them for whatever reason they choose that method. But the national data shows that it's not effective because most women that use it experience high rates of unintended pregnancy. And also, we can't count them in claims. We don't know, there's no code for that we could count. And even if there was, it really wouldn't qualify as an effective method. So it's just one of those places where it's just going to end up in the portion of the denominator that doesn't get counted in the numerator. But again, just asking for a small budge in the numerator, going from 34 to 37%, acknowledges that there are a lot of other women using other methods of contraception that aren't going to get counted, and we just want to make small improvements. Okay, so moving on. There is a national metric being developed by Centers for Medicaid and Medicare Services. It's currently in draft form, and they've put out an RFP for states who want to study it and collect some data on it. Oregon applied for that and got it. So we're going to be collecting data for the CMS metric as well as this one, and basically doing a side-by-side comparison to figure out who got the specifications right, or better, I should say. No, we don't know that either one of them is right, but how is our data different with the different specifications? So we'll be looking at that and trying to refine this metric and make it better in the future. The CMS metric is broken up by age. It's basically effective contraception used by women ages 15 and 20, and then effective contraception used by women ages 21 to 44. In addition to breaking out the metric by age, each metric has a two-part numerator. So for women 15 to 20 years old, how many of them adopt or continue to use the most effective or moderately effective methods of contraception? That's tier 1 and tier 2. And then the second part of the numerator is how many of them specifically adopt or continue to use a long-acting reversible method of contraception. I will point out here for the questioner at the beginning of the presentation, I have a very big problem with this. They specifically, the national metrics goal was to look at LARC use. LARC is long-acting reversible contraception. It refers to IUDs and implants. And they wanted the metric to just be how many women are using a LARC. And that is where I think it borders on the, what the questioner asked too, that it looks coercive. It looks like we are pushing one method, especially on poor women, and I have a really big problem with that. And when we were developing the metric in Oregon, there were a number of us, not just me, but a number of us felt very strongly that we not call out specific methods of contraception, that we keep the numerator very broad, and that women had a huge range of options of which method they wanted to use, and that we didn't want to specify LARCs for exactly that reason. It feels too much for me. The way that they describe it in CMS is that the first part of the numerator is an intermediate outcome measure, and the second measure is just looking at access. They just want to see that enough women have access to this method because other studies have shown these are the methods that many women want. So the concern is that women who want this method aren't getting it, and they wanted to approach it that way. We didn't do it this way in Oregon for reasons that, because we're just looking at the Medicaid population, and it didn't seem to respect women's choice in this and a person-centered approach to contraception care. We don't want to push any certain method. So in their denominator in the CMS metric, they exclude women that can't get pregnant just like we do, but they also exclude all women who were pregnant during the delivery year. They don't acknowledge pregnant women in this at all, so they don't get credit in this metric for contraception. And so then in the numerator, they find women who are in the denominator who are using tier 1 or 2 methods, and then specifically women using IUDs and implants. The option to surveillance codes, and I want to make this clear for people who are concerned about how annoying the surveillance codes are, the option that they do not do surveillance codes in the national metric. Instead, they reassign 1.4% of women who are using or no method at all to the most effective contraception group. Basically, they say, okay, we found, I'm making it up, but we found 20% of women are using a tier 1 or tier 2 method. We're going to assume that an additional 1.4% of women had an IUD inserted last year. So we're going to just increase our numerator to 21.4%. Again, that's based on National Survey of Family Growth that tells what methods women use. So, but they're just going to make an assumption and then increase their numerator based on that assumption from the survey. The other thing that they do is a kind of a complicated workaround around IUD insertion codes. They want to be very specific for the second part of this numerator around IUD, so they do a specific check to see if women had it removed and then reinserted. We didn't go that far in our metric. Basically, if there's a code for an IUD, we assume it's still in, and we didn't do this workaround. So in Oregon, we're trying to count postpartum contraception in this metric, and CMS is excluding everyone with a pregnancy, and they want to focus on a separate postpartum contraception metric. So that's the way they handle it. That's one of the key differences between our metrics. And then in Oregon, we're using surveillance codes to find women with multi-year methods, and at CMS, they decided to just use an educated estimate to assume an additional portion are using effective methods and increase their numerator that way. I don't know which way is better. That's what we're hoping to find out with this grant proposal. We're going to collect a bunch of data. We're all trying to figure this out together. So, so that's kind of the differences there. Any questions about the CMS metric? Have any other questions come in, Kate? Otherwise, I'll just keep moving.
We do have one, but we can hold it till the end. I know it's 9:30, so for folks who have to go, thank you for joining us. We're going to keep going. For anybody who can stay on, please feel free to and still type in your questions. Happy to take them just a little bit past 9:30.
Okay, so I'm going to go through these quickly because these are the strategies to improve your method. I really think this will only be about another 5 minutes, so please hang in there with this. First of all, make sure you're getting credit for what you're already doing. Make sure that all visits that include contraception are properly coded. A lot of clinicians do contraception as an add-on to the visit. The woman's there for some other reason, and they address the contraception as an add-on, and a lot of times that doesn't get coded. So make sure that they're coding it every time it happens. And then asking women once a year about their method, if they still use it, if they're happy with it, and coding for a surveillance visit. I want to point out that some CCOs are considering using nurse phone calls. So scanning their records to find women who have had an IUD or tubal ligation in the past few years, and having a nurse call them up and say, are you still using that method? Is it working for you? Are you happy with it? Do you have questions or concerns? And then billing that as an RN triage visit. And that seems to be a viable solution. And then the nurse can include the surveillance code as part of that. She can bill for the phone call, like any other nurse phone call, and then she can include the surveillance code for contraception. And that way you don't have to do the surveillance as part of a clinic visit. The second thing I would recommend you do is that you inventory your clinic and streamline your services. Make sure you know which methods that you can provide in your clinic, which ones women have to go elsewhere for, and get a real clear sense of that so that you know where women can get IUDs, implants, or sterilizations. If your clinicians want training on IUDs and implants, as I mentioned, there are free trainings both in Portland and in Medford coming up in October, and I really encourage you to check those out and send them. The links are at the first slide for registration. These are the CDC-sponsored guides on family planning that have come out in recent years. These are excellent. The Quality Family Planning one is an overall guide to providing family planning services. The medical eligibility criteria on the right talks about if women have medical complications like diabetes or a history of breast cancer, which contraception methods are appropriate for them. It gives an excellent, excellent chart. It makes it easy to figure out complicated contraception care. And then the bottom one is selected practice recommendations for contraception care. It talks about things like the fact that you don't need a negative STI screening before you put in an IUD. You don't need to do a pap and pelvic before you give women a year's supply of contraception pills. These are all the evidence-based recommendations for the actual process of providing contraception, what's required, what's not, how to be reasonably sure a woman isn't pregnant if she comes in and wants a depot shot and she's been sexually active and you're worried she might be pregnant, how to be reasonably certain that she's not. It gives guidelines for all of that, and it's a great tool. All three of these are really well worth having at your clinic to reference for contraception care. These are the folks that are coming to Portland and Medford in October. It's the Bixby Center for Global Reproductive Health. They did a great study published in The Lancet showing that when clinicians got this training, they were much better at counseling for IUDs and implants, and they were actually trained to insert them. And in their study, going through this training reduced unintended pregnancy rates in these practices by half. It was a very important study, and that's why we're bringing them up here to train clinicians specifically in addressing this metric. I think this is the most important thing you can do for improving your performance on this metric is help make sure your clinicians are up to date on their counseling strategies for IUDs and implants. If you want to schedule your own training, there's the contact information. If you can't make it to the ones we scheduled in October, they're happy to come out. You have to have at least 30 people for the training, but I encourage you to talk to them. And then build partnerships with family planning clinics and OBGYN clinicians. If you don't have somebody in your clinic that can do IUDs and implants, make sure you know where they can go in the community, who in your partner is providing them, where would you send women for complicated IUD insertions or removals, make sure that women can get all the care that they need in reproductive health. And then get proactive. You can scrub charts of women of reproductive age. That's a basic function of a primary care medical home, is looking in advance for things people might need. If people are coming in for a visit, you can scrub their charts to see when's the last time contraception was discussed, and make sure that some mention of surveillance or counseling is in there. And then you can screen women routinely for their pregnancy intentions. So in places where the political environment is a little bit tough for talking about contraception, and I know that happens in a lot of places in Oregon, one key question is a really great strategy for bringing it up. It's an initiative that is sponsored by the Oregon Foundation for Reproductive Health, and it basically proposes that you, instead of asking women about contraception, you ask them would they like to become pregnant in the next year, and then you follow up with their responses either way. So if you're interested in that, this slide here shows the website. You can contact them at www.onekeyquestion.org and do a proactive approach to contraception planning. And that's all the slides I have. And if anybody wants to stay on and ask further questions, I'm happy to stay on. I thank all of you for your performance, and please feel free to get in touch with me offline as well. If you have further concerns, I'd be happy to talk by phone or by email about any other pieces of this, and include Sarah Butterman on the conversation. She's the expert on the specifications, so please let me know.
Great, thanks. So if anyone has any questions they'd like to submit, please do it now. I think it's just one more, unless we get some more in. So just a quick reminder, a copy of the slides and the recording, actually, of this webinar will be available on the Institute website by the end of the day tomorrow. Those of you who've registered should get an email from GoToWebinar to remind you that they're there. And if not, try and remember to check back, because they will be there for you to use and share. Then the question that we have was, is there anything about reproductive coercion in the metric? So reproductive coercion screening, knowing that the provider goes over birth control options that are less detectable to batterers, or how do we get that important topic included in the metric, or out there more?
Yeah, this is a place where it's not really appropriate to have that as part of the metric. That's a part of really high quality care for women, but metrics are kind of limited. Metrics are just one piece of the quality puzzle. There are many things we do to improve quality, and metrics is just one of them. So yes, so we recommend, of course, screening all women for intimate partner violence, including reproductive coercion, and there are some efforts around the state at screening women for during pregnancy for their risks of mental health, substance use disorders, intimate partner violence, or other issues that could be impacting their well-being, and it certainly is included in there. I obviously recommend that clinicians get extra training and make sure that they're aware of those issues when they counsel women on contraception, but it's not at all part of the metric. Again, that's a clinical issue that we can't really find in claims if it was done or not. Some of those counseling issues are really tricky in claims. We don't code for everything we talk about.
Great, and so the person just shared that Futures Without Violence has free and good training tools available online for anyone else interested in learning more about that specific topic. So I think with that, I want to say thanks to Dr. Blanca for joining us on today's webinar and all this really helpful information about the contraceptive metric and sort of the innovative cutting-edge work that we're doing in Oregon. So thank you to her for sharing all this information with us. Thank you all for joining us. As I said, please do complete the post-webinar survey and look for the slides and a recording of this webinar to be posted on the Institute website later today or tomorrow. Thanks so much, everybody. Have a good rest of your day.
Thank you, Kate.